So this is the first webinar of this 2024 of Asian Heart Society. And I shall be talking about next 20 minutes about the epidemiological diversity of hypertension and lessons learned from May Measurement Month campaign, which we run in India. Myself, Professor Anuj Maheshwari. I am Secretary General of Indian Society of Hypertension. At the same time, I am also President-elect of the Asia Pacific Society of Hypertension. So, taking you towards the presentation, what I am going to present today. We all know about the high systolic blood pressure, which is the most important risk factor for the global disease of hypertension. Now, high systolic blood pressure has become one of the most important risk factor and most prevalent risk factors across the world about the global burden of disease study. As far as the global burden of disease study is concerned, in India, we find that hypertension is again an important risk factor, contributing 1.9 million deaths and 48.2 million dailies lost per year. Particular matter pollution is one of the important reasons which comes on the highest level. The particulate matter pollution, which is related directly to the pollution, followed by the high blood pressure, and then it comes with the diabetes and smoking and unsafe water, which are the common causes of deaths in its preference. As far as the Delhi's loss is concerned, again the particulate matter pollution comes first in this list, and high blood pressure follows it. The same chronological order as we could see in the deaths of which are caused by the hypertension and their risk factors. So these are the few new risk factors which has been added up to the one is the pollution, and we can say that another one is unsafe water. CVD is the most common outcome of the hypertension. Cardiovascular disease like coronary heart disease, stroke, heart failure, both with reduced ejection fraction and preserved ejection fraction. And apart from this, there are some other causes of CVD in the patients of the hypertension, which are chronic renal failure, peripheral arterial disease, and potentiation of the adverse effects of the diabetes, obesity, and cardiometabolic conditions. And apart from that, there could be some other and miscellaneous causes also, which may lead to the cardiovascular adverse outcome in patients of hypertension. So if we look for the proportionate CVD deaths in patients with hypertension, in as per the global burden disease study of 2019, what we could see that South Asia is running almost at fourth place across the world in the chronological order or in the downward trend order. Highest one is the Europe, and then followed by the Southeast Asia, and then we can see that European Union followed by the South Asia. So if we talk about the another study, which is known as the pure study, which has been done in the India, Pakistan, and Bangladesh, median follow-up of 11.5 years, we could see that hypertension is one of the highest burden for the disease-causing agents and leading as a risk factor for the cardiovascular disease, apart from other risk factors which are well known to us. In this pure study, what we could see that major cardiovascular events every 1,000 person years, as far as women and men both are concerned, what we could see that 8.74 is the men, while in the lower income group and the higher income group was a 3.96. As far as the men are concerned, lower income group, it was a 13.6. In the higher income group, it was 7.35. So in nutshell, we can say that hypertension has been no longer a disease of the higher income group or affluent group. It is actually has been a disease of the poor income society, lower income society, and actually it is unmanageable also with them because highest level of the mortality also seen in the lower income group of the patients. So we talk about the lowering blood pressure. Obviously, it is well known that lowering blood pressure is well protective. In a meta-analysis of BPL-DTC, what we could see that per 10 millimeter mercury of the systolic blood pressure lowering can really cause a sizable risk reduction. It can lead to 20% risk reduction in major CVD events, 17% risk reduction in coronary heart disease, 27% risk reduction stroke, and 28% reduction in heart failure, and 13% risk reduction in all-cause death. So if we look for the challenges of hypertension control in South Asia, the first challenge comes from the increasing burden of the hypertension, which has to be stopped. We all are suffering across the South Asia that number of hypertension cases are increasing day by day. Significant geographic and SES based inequality in hypertension is again a matter of thought, and we should think about that. It's again uh, 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 a thing which to be acted upon on this challenge. So look forward, how does it works here? Declining hypertension globally, what we could see, but it is increasing in South Asia. You can see that in Western population, high income Western population, Central and Eastern Europe, Latin America and Caribbean, high income Western population, and Central and Eastern Europe, even in women and men both, the you can see hypertension is the downward trend. Only it is in South Asia you can see both in men and women it is on the rising trend. So this is a most dangerous thing for our population who is living in South Asia, that hypertension is still on the rising trend despite it is on the downward trend rest of the other parts of the world. Similarly, what we see since from the 1945 to 1995, we can see the blood pressure which is at the high level of hypertension more than 160 by 95 on the rising trend as per the various trials which has been done in the urban and rural. And what we could see that as the time is growing, this urban-rural divide till the 1995 was well maintained. But after that, it has started coming closer. And now we can see in 2013, this urban and rural gap is getting lesser and lesser, and this divide is coming closer to each other. So now the urban and rural hypertension is not very much different. The prevalence of hypertension is no longer is having any difference between urban and rural population. If we talk about the hypertension prevalence in India, in women and men both, what we could see age more than 15 years of the data population 2019 to 21. Individuals with hypertension, we could see that 33 to 42% hypertension was found to be in very small areas in women and in men both. In men, it was a little bit more, but in women, it was in very small areas what we could see. Majority of the people were 23 to 27% of the majority of the geographical area of the India were having the 23 to 27 and 28 to 32%, especially in the male, but in the women, it was still keeping the 15 to 18% of the hypertension prevalence. But ICMR in-diab study, which has been done in more than 20 years of the age group, we could see results were actually different and they were quite eye-opener. Individuals with hypertension, as far as 300 to 331 million, 0 to 19.9% were rarely we could find any part of the India. But majority of the Indian area, what we could see, it was having more than 30% prevalence of hypertension, especially in the South India, some part of the North India and Northeast part of the country. Hypertension prevalence in women, if we look for that, we can see again it is still much lesser than men. What we could see here that we are, but this gap is getting closer and closer, and it is not going to be much different in the future when we shall be looking for this difference. Increasing hypertension in the young also in India between the age of 15 to 49 years. Change in the hypertension prevalence is occurring very fast, and we can see it here that hypertension population in the youngsters, even less than 30 years of the age, are growing very fast. So inequalities in South Asia, which are actually responsible for this growing burden of the hypertension, increasing blood pressure, regional variations, and we must learn few lessons from the United Nations SDC. In fact, public health policies which are required to be targeted towards the universal and free primary and secondary health care, which can really help in reducing the growing hypertension population, socialized and state-funded health services, screening programs to be much more frequent and prevalent. Food policies and nutrition should be taken care policies to curb salt, sugar, and trans fat, and we should try to promote fruits and vegetables, and especially tobacco and alcohol should be on the strict control. Maternal and child health to be taken care well so that fetal nutrition and maternal nutrition, especially when she is pregnant, should be taken care well. Curbing salt and sugar intake in early childhood because it leads to the foundation of hypertension in early age. And obesity prevention is also a part of this early childhood prevention. And we can really reduce the insulin resistance in the people, so which is an important reason and which is one of the main cause of hypertension in addition to the diabetes. Endothelial dysfunction is one of the important reason which is arising out of this insulin resistance in the early age, and that goes on causing the atherosclerosis when a person grows up and becomes adult. Education promotion, health literacy, and poverty eradication. Job and income guarantee schemes should be one of the important tools for addressing these healthcare systems. So if we talk about these inequalities, hypertension is one of the social disease that needs to be solved socially. It needs some of the social solution which may require some political interventions. Focus on the social determinants is again is one of the important reasons. Neighborhood and built environment, economic stability, education, social and community contacts, healthcare access and good quality of the healthcare availability, social determinant, which are the important social determinants of the health in these five domains. And it directly affect the health and well-being of the individuals, and which gives us the good health outcome if we perform then to our population. Now come over to the another challenge, that is a challenge two. Challenge two is the low status of the hypertension awareness and treatment. Very low levels of the hypertension control. Many people does not know whether they are hypertensive or not. And if even if they are knowing that they are hypertensive, they don't do anything for control that. Even if those who are started on medication, they stop the medication whenever their high blood pressure comes down to normal. So what exactly can be done and what is the target we could do in this part of the challenge? Trends in the hypertension awareness, treatment and control. As per the available data, we can see that a big part of the hypertensive population is still undiagnosed. If you look over to the population which is hypertensive, very small part is the controlled, remaining part is treated but not controlled. That's part which is more than 50% is either undiagnosed or even if they're diagnosed, it is not controlled or not treated even. In high income Western population, in high income Asia Pacific population, almost the situation is the same, but East and Southeast Asia, you can see almost in all parts of the world, you can see the undiagnosed population is the highest. But in the East and Southeast Asia, there is a sizable part of the diagnosed but untreated part is also there. So this is again an eye-opener data. If we talk about the national studies of hypertension awareness treatment and which are done in India, what we can see here that as far as the awareness treatment and control is concerned in men and women, what we can see that women are having good awareness of the hypertension, but it's still less than 50% control of the hypertension. Less than 50% are taking the treatment, and obviously, little bit more than the 50% of that, those who are taking the treatment are getting control of their hypertension. As far as the men are concerned, much lesser number of the women are knowing about the hypertension. 9.8, when one-fourth of them who are knowing about the hypertension, they are getting the treatment, and around 50% only are getting control. If we talk about the people, those who are 45 plus age group, again we can say women are performing better as compared to men. 57.8% are aware, 43.1% are taking the treatment, and 29.8% are controlled. On the other hand, males are taking 36.1% are aware, 28.9% are taking treatment, and 16.4% are controlled. So in this way, we know that 25-year trends in hypertension awareness, treatment, and control in India. What has been seen in Jaipur Heart Watch study from 1991 to 2015, what it is on the rising trend in last 25 years. Come to the challenge 3, because that is one of the most important thing, achieving control and reducing cardiovascular events. All exercise is being done, taking this thing in the mind that ultimately we have to reduce the cardiovascular events. What can be done for that? What are the things which may lead to the pathways towards the better hypertension treatment and control? Bureaucratic approach, political focus, development of the health system, healthcare financing, technological support, health system approach, health system is strengthening, low cost medication can be provided, uninterrupted supply of the medication should be there, healthcare provider or physicians should be having enough time to educate the people, task sharing. They may not be one person is not burdened with the multitasking. Clinical approach should be there with the adherence and promotion of the treatment adherence. People should be having the responsibility of the treatment adherence, and patients should be empowered to increase or reduce their doses as per the requirement. Many a time, every time they may not come to the doctor or physician may not be available every time to them. As far as the health lifestyle, focus on healthy diet, exercise, tobacco and alcohol should be withdrawn from the life. This simply may be enough for the low risk hypertension, and BP control could be. And obviously, getting by the lifestyle management only. But little intermediate risk and little more risk, we should look for the lipid management also. In addition to the lifestyle focus, maybe diet, exercise, tobacco, alcohol, blood pressure control, lipid management together. And in high risk patient, we should look for the antiplatelet therapies, diabetes management. We should try to have the polypills treatment, uh, fix those tablets and fix those preparations should be given to the patient, and multifactorial interventions are required, especially when multiple comorbidities are there. Now I shall be telling you our own experiences, which we could be able to do while doing the May Measurement Month campaign in India. These were the publication we could do after starting the May Measurement Month campaign 2017, 2018, 2019. We all know 2020 was the COVID year. And in COVID year, we could not do that. But in 2021, again was the COVID year, having a lot of effect on the COVID on the hypertension prevalence and population. What we could learn of this May Measurement Month campaign, white collar people and housewives are carrying high risk with undetected hypertension in India. Very few people were having their focus on the housewives, those who are working in the homemakers, and they are really being targeted for the hypertension, and they are not knowing about that. Thanks to the May Measurement Month campaign, which has targeted towards the who have never measured their blood pressure, and we could catch them, those females who never measured their blood pressure and make working as homemakers. Now, another important thing in the due course of the time in last few years, many of the organization has reduced the cutoff for the hypertension. Lot of hue and cry has been raised when the cutoff has been reduced for the hypertension diagnosis from 140/90 to 130/80 because it was raising the prevalence of hypertension from 16.49 to the 44.71, means three times extra healthcare burden is going to come up. But we need to understand this 130/80 and 140/90 is not simply a cutoff. It is actually giving you a good quality of life if you are maintaining the 130/80 mm of mercury blood pressure since from the early childhood, and you can help in adolescent age group, you can help your patient to keep their blood pressure in this range without any medication. And obviously, this is not simply a healthcare burden of a government or simply a not healthcare burden of some society. Similar trends in the genders could be seen from all the three studies of 2017 to 2019. What we could see that in males, the blood pressure remains higher till the age of the 65 years, and but after the 65 years, females crosses them in the systolic and diastolic both. As for the variable trends among the various conditions are concerned, those conditions may be the previous stroke, previous myocardial infarction. We could see that blood pressure have been found to be on the lower side, systolic and diastolic both. But people, those who were having the antihypertensive medication, those who were known for their hypertension, and those who were diabetic, they found to be having their blood pressure little raised when they have been measured with that. And this trend has been followed in 2017, 2018, and 2019, all the 3 years. And if we talk about the weight into the consideration, obesity was definitely has been found to be a risk factor for the hypertension without any doubt. And when we could saw the other parameters like pregnancy, like alcohol intake, like smoking, and even fasting, what we could see, they all were causing increase in the blood pressure except the pregnancy. And some of the patients have been found, those who were taking occasional alcohol were found to be in the systolic lower category that might have been the accidental or just an incidental. We have also seen in those patients that which day of the week the blood pressure remains highest. We understand usually it was our thought that Monday and Tuesday when we start the week, maybe we are having the highest level of the workload and maybe our blood pressure was higher. But you will be surprised to see that Friday and Saturday were the blood pressure highest, and highest was the Saturday when the blood pressure was on the highest level. Variation by the site at which site the blood pressure has been measured. We could see that public area, the blood pressure was found to be least and it was highest when it has been done at the workplace or some other place, maybe the clinic, maybe the place where might have been patient working or doing something. So if we compare the prevalence over the 3 years, what we could see the overall downward trend could be seen in the prevalence in Indian population with the May Measurement Month campaign. And May Measurement campaign has been very much useful in this downward trend of prevalence. And this could be seen not only in the patients, those who are hypertensive aware, those who are taking medication, but also overall hypertension patients have been found to be showing the downwards trends in the prevalence over the 3 years. So what we can do it here as a conclusion of this Southeast Asia hypertension nexus. health equity is one of the important thing what we could do with the inequities in the control. Earlier age of the onset is there and is to be taken care. Premature mortality, ethnic discrimination, and generational issues are there to be taken care for the health equity. Engagement is to be done for the silent conditions, biological milestones, health belief model, social stressor, lifestyle behavior, shared decision. Measurement, if there is an issue whether to do the blood pressure measurement in office and home, and Dr. Verma would be showing more light on this issue, white coat and masked hypertension versus sleep. Implementation can be done. How can it be the best way of implementing? What could be the role of the polypill and fix those combinations, validity, feasibility, and accountability of the measurement methods and implementation of the hypertension treatment, and what could be the finally outcome, and ultimately if the patient is getting the health outcome in a better way or not. And this is the thing what we really look forward. So if we talk about and if we go to the finally to the lessons learned, this community-based screening for hypertension in India, which we could do in the form of the May Measurement Month campaign, provides unified insight into varied epidemiological pattern for screening and detection of hypertension. Relatively younger population with hypertension requires the policy framework to be designed to allocate judiciously resources to manage hypertension disease burden in India. In India, about 70% population of the less than 40 years of the age. If we find that 30% or 35% people are suffering with hypertension, obviously big group of the younger individuals is also suffering with the hypertension. And we should do something different and they should have a different policy. Obviously, the poor treatment adherence and clinician inertia is a big problem across the country. People are not taking their treatment despite knowing, which has been proven by multiple studies, including the May Measurement Month campaign. And of course, we all understand this that India specific guidelines could be a solution for the characteristic hypertension because we could see a lot of youngsters who are suffering with the hypertension, which was coming up due to the sympathetic overdrive largely. So later on, we could thought on this way and we tried to make the India specific guidelines for which my next speaker, Dr. Narasimha, shall throw some light on those guidelines which we could do after getting the data from that. Thank you very much for the kind